Hello, everyone. Happy Thursday. Welcome to version 1 billion of this iteration. It's just as awesome and just as fun. Many iterations on. Today, it's an all-eternal affair anchored by Julia and Masa, who are describing and teaching points respectively. So maybe I should always honor them first and thank them for what they're doing. So, Julia, do you want to say hi and tell folks what you're up to?
Sure. Sorry. Hi, everybody. I'm honored to be part of this family. I think that's all I want to say for today. Very excited. Looking
Tell us
forward.
about your decoration. It looks really cool.
Yeah, some Christmas feelings around.
Mhm.
There hasn't been any snow in Germany yet,
Yeah.
so we've gotta hold up the decorations.
Awesome. I'll tell you, I'll guarantee you there isn't snow where Masa is either. Probably ever. Yeah?
Hey everyone.
Mhm.
No, we don't get snow. We got snow like in a city, the city where I did my med school in, which is like 2 hours away from here, because it's like full of mountains. So like they had snow, I think like 2 years ago on the tip of the mountain. That's all.
Like the very, very, very top.
Very tough. No one could get there. That's
What's the weather like
it.
now? How warm is it even in the
Oh,
winter?
now it's so nice. Like
Yeah.
we just want to be outside all the time. The
Yeah.
wind is winding. The weather is weathering. It's really
When
good.
it when is it like a sweet spot in terms of climate?
Now, like
Yeah.
end of November until May, April, something like
Really,
that.
all the way until April, huh? Oh, okay. That's
Yeah, it's
awesome.
like so nice the whole time. Like this is our beach weather.
Dead winter is beach weather. I love it.
Yeah.
I think the same is true for our case presenter today, Ibrahim. What's the weather like in Saudi Arabia?
Yeah, I don't know about Basra, but here it's almost always hot. I think
Yeah.
today 40 Celsius centigrade, even though
Oh
we are
my.
approaching winter.
Winter.
So yeah, we almost ne we never actually see one like snow in Jeddah, where I'm based.
Yeah.
But I think other parts of Saudi definitely see snow.
Yeah, what
Uh,
parts of Saudi see snow?
so usually, just like Masa mentioned, so the southern region of Saudi Arabia has a lot of mountains.
Hmm.
Uh, and so they usually see snow there. And then there's also the northern region of Saudi Arabia,
I see.
uh, where like they're currently building the mega projects and everything else.
Yeah, yeah,
They
yeah.
see a lot of snow during the winter.
Have you ever been to any of those regions yourself?
No, I've been to a place called Abha, which is like in the southern region of Saudi, but
I
like
see.
not so far into the south. Yeah.
I see. Amazing. Well, hey, I'm really excited for more storytelling from you through your case today. Thank you so much. This is case number 2 for Ibrahim, who is probably presented many, many more over his almost 2 years in CP Solver now. Are we at 2 years, Ibrahim, or more?
Yeah, I think I stopped counting, but I think yeah, I'm approaching 2 years.
Amazing, amazing. Well, hey, you know the drill. We celebrate people today, Johann, as they're beginning their journey in CP solvers by inviting them to go discuss a case. We can't think of anything else that honors people's hard work and commitment to the cause. And so I'm very, very excited to hop over to Spain now, but originally from North Africa to tell you all that Johan has been crushing it in the realm of CP solvers, and we're very, very excited to honor that progress by diving into an Ibrahim case. So, Johan, I'll hand the mic to you to say hello, tell us what's new in your life, and we'll jump right in.
Hi everyone, I'm Johan. I remember almost a year ago I presented my first case at TP Solvers and I actually rewatched it a few days ago when I saw my name I think on Sunday on the weekly list and I was like, damn, oh okay, I'm going to present a case to discuss a case now. And I presented that case and I was like, okay. I started thinking about my thought process at the time and what I was going through. And it
Mm,
was just so different because I was, still trying to, I was still doing rotation and I was trying to, impress PD to have the amazing letters of recommendation. And now I'm discussing my first case at a completely different step of my career where I'm now interviewing and trying to impress PDs as well, but to
mhm.
get into a good program. And I'm sure that in maybe first tomorrow I'll rewatch this case to roast myself and say, hey, how can you miss that easy diagnosis? But anyway, I'm sure that in a year or two I'll rewatch it And I will be so proud of myself, watching me discuss my first case online, Prime TV. So we'll be discussing today.
Hey, well, wherever you have Julia Ibrahim and Masa, you have Prime TV. I completely agree with you. Wow, what a great intro. I completely agree with you. It's always such a wonderful thing to look back in the past and see how much progress you've made. So yeah, without further ado, let's jump in and make that progress. Ibrahim, the mic is yours.
Alrighty. So for aliquot 1 for this case, this is an 18-year-old male who has progressively developed generalized myalgia and diffuse muscle weakness since the past 8 months.
Yeah, Johan, if you're hearing this story and you're imagining what's going on, I'm curious what thoughts are crossing your mind.
Yeah, so 18 years old, I mean, it's pretty young first,
Yeah.
and progressive myalgia over 8 months with, diffuse muscle weakness. So first, it's a sort of chronic process, it took time and it's progressively, I guess, getting worse. So for now, we don't really know about the acute. Is he coming to the hospital because it's getting worse and now it's just so acute that he just need an acute help? Or is it just a chronic process that has been bothering him, but with a sort of low intensity type of process? And when you say progressive myalgia, I want to know if he's able to, exercise, and is it maybe painful when he touches muscle? But overall, at 18, with this type of presentation, I would like to know more about the history of autoimmune disease in the family, maybe to get a bigger sense of what's happening, but overall have more information on the HPI.
Yeah, no, I completely agree with you. I think you're latching onto the very intriguing age of presentation and how that changes the current context. And I think latching on to the time course, which is also very intriguing. I love that you're open to the fact that the patient's choosing to present now, and so there may be a change in the time course, which means that the disease may have accelerated, or of course, it may have reached a crisis point where it can't progress anymore without a crisis. And I think those are the two distinctions. I think it's very powerful to ask ourselves what kinds of questions will allow us to make progress. Is it questions with regards to the patient's risk factors, be it genetic risk factors, autoimmune risk factors, or is it questions that help us understand where the problem is? So, Johan, if you were to query your mind, are you going to get more advancement in this case by getting information related to the myalgia or weakness? Or do you think you'll make more advancement in this case by understanding the risk factors for whatever this disease is? What do you think?
I think honestly it would be a bit of both, but if I have to prioritize
Yeah.
something at 18 with no history of trauma or anything like that, I will prioritize, autoimmune and genetic condition that can lead to that presentation overall.
Yeah, I think it's a tricky situation, quite honestly, because it really illustrates how it's actually very tempting to ask to translate these two things into a muscle problem. And then you're starting to ask, what are the risk factors for muscle disease? And which category we go into is really a function of how confident we are about what this problem represents. Because if this turns out to be asthenia and painful asthenia, your review of systems may be very, very different than if this turns out to be a painful myopathy. It may also turn out to be a painful neuropathy, and your risk factors and questions may be so different. So I guess it really hedges on how confident we are that this muscle ache and muscle weakness is a muscle problem rather than a distractor where the patient is hurting, saying it's muscle weakness, but the lesion is somewhere else. So I guess that's the conversation we should have. How confident are you that this is in fact a muscle problem? What would you say?
Yeah, that's really interesting. I'll say overall, I see, two different paths. Maybe it's not muscle and maybe it's just, weakness. And when I think about weakness, I can think about a neuropathy. I can also think about, depression. I can also think about, endocrine issues and basically electrolyte issues as well
Nice.
that lead to weakness. So first, I'll, need to have more information about the physical exam itself. Is it actually just weakness, or is there a real muscle component to it? So actual muscle pain, I'll start thinking about maybe, polymyositis or maybe dermatomyositis and checking, I don't know, the specific lesion that you have in this condition. But overall, I want to keep my differential as broad as possible for now and gather as many information as possible in the HPI.
I completely agree with you. I think it's very tempting to say this is a muscle problem, but I think you have to be a little bit careful and need more information. And I think the best way to understand this is to go back to a place we're familiar with, which is the heart. And so you ask yourself, when the heart muscle weakens, i.e., the patient has heart failure, what percentage of those patients also have heart or chest pain? Very few. Most people who have heart or chest pain do so because of an acute vascular insult to the heart muscle. The same is true for skeletal muscle. Most people who have skeletal muscle pain have an acute vascular insult termed rhabdomyolysis, where as a result of a substance like cocaine and exertion, a demand supply mismatch is created where you take a vasoconstrictive substance, which makes you walk, and you develop a supply demand problem that causes you to hurt. But most of those patients don't have weakness, they just hurt. No different than most patients who have acute coronary syndrome. They often don't have heart failure unless it's very, very severe. So I would say that the presence of pain and weakness is unusual and may suggest that the problem is not in the muscle or suggest a subset of diseases of the muscle that are characterized by necrosis or death of muscle. And it's really those diseases, necrotizing muscle diseases, that cause both weakness and pain. If you just listen to the chief complaint and you come to the conclusion that a patient has a necrotizing muscle issue, you should check yourself. It's a very rare conclusion. It's not like necrotizing muscle diseases grow on trees. They're very hard to find. So I would say the reason I'm cautious is because just like heart muscle failure, skeletal muscle failure is almost always painless. And the presence of pain here is giving me pause to make sure we're not solving the wrong problem, i.e., asking the wrong history, the wrong risk factors, the wrong genetic history. But if in fact it turns out to be muscle disease, then we are in a very specific domain of painful muscle disease, which we can often translate into necrotizing muscle disease, which has a differential diagnosis, but is much narrower than the differential diagnosis of all muscle diseases. So like you, we need a lot of more information. I'm invested more in trying to figure out where the lesion is, muscle or not, weakness or not. And after I sniff out and clarify what the patient's current issue is, then I know with more confidence what kind of risk factor questions to ask. So in other words, the what this patient has is too nebulous for me to start to ask why do they have it. And the questions about genetic disease, autoimmune disease, meds are questions about why. Why would you have this? You have this because your mom had it. You had this because you have a history of autoimmune conditions. The why is much more valuable when you know exactly what the issue is. So let's pay close attention to that HPI to see if we can make progress on what this problem is. Awesome job. All right, Ibrahim, the mic is yours, my friend.
Alrighty, so thank you for the wonderful discussion. I don't think I've ever heard someone talk about muscle weakness for 15 minutes before. But I'm already learning
Oh,
a lot.
Ibrahim, don't tempt me. We can talk for 30 minutes.
So thank you, Juan, and thank you, Robbie, as well. So for the HPI for this patient, uh, you're on IM service and you get paged by the AD about this patient. Once again, they're an 18-year-old male, and you learn that they're a known case of G6PD. You go to see the patient, and once you enter the room, the first thing that strikes you is the wheelchair next to the patient's bed. You look at their vitals next to their bed, and they seem vitally stable, but they're a bit hypotensive. So their vitals in the ED were, their temperature was 37.3, so they were afebrile. Their BP was 82 over 55. Their heart rate is 85. Their respiratory rate is 19, and they're satting 100% on room air. Generally, your patient looks conscious, alert, oriented, but they also do look pale and cachectic. Um, and so you try to take in some history from his mother, who's been accompanying him. And the mother tells you the following. So she tells you that he's a known case of G6PD once again, and that his story had started 8 months ago when he started complaining of on and off fever that was mainly at night, that was responsive to paracetamol, which is acetaminophen. They tried visiting multiple private hospitals, approximately 3 to 4 times, but they were always discharged without a preliminary diagnosis or a treatment for his condition. And then 6 months later, the patient started to complain of decreased appetite, easy fatigability, and unintended weight loss. And their baseline was at the time 47 kgs, and they lost almost 7 kgs in 2 months alone. And then they progressively developed generalized myalgia and diffuse muscle weakness that has been there since the start, to the point that he now requires help in his daily activities of living. He's currently on a wheelchair, and he is unable to talk or move. His systemic review was positive for decreased bowel motion, so he's only been having one bowel motion per week. But his mom tells you that this might be due to the decreased oral intake that he's been having because of his low appetite. Otherwise, there is no history of jaundice, no history of melena, of nausea, of vomiting, of hematemesis, of skin bruises or hematuria. There is no history of shortness of breath, cough, or a recent upper respiratory tract infection. There is no history of dysuria, urgency, or frequency. And there is no history of contact with a TB patient or a history of TB in the family. And I'll leave you with that.
I can see why you stopped counting how many years you've been with CP Solvers, because if you told us it's been 30, I think everyone would believe it. What an incredible presentation. Love the storytelling. I feel like I can visualize this person, which is amazing. So Johan, what do you think happened to our hypothesis of muscle disease? Did it weaken or did it strengthen?
First, amazing presentation, Ibrahim. You're not, I mean, we will have to talk after this meeting. Anyway, so yeah, I think honestly with the slow process and the fact that at some point it just started getting worse and worse made me push me to think about all these uh, muscular dystrophies, especially in a country like Saudi Arabia, where like many countries in the global south, there's a lot of marriages in the family. I think it might be more prevalent there, or it's I mean anyway we have to think about it as well. So it's not uncommon to have this presentation at a later stage. And I also think about this mitochondrial disease where you have an increased lactate and it can actually give you muscle pain as well, I think. And overall, I think it just pushed me toward the genetic and autoimmune and autoimmune path more, especially since the patient has G6PD and there is no triggering event. before starting getting weaker and weaker. So overall, I think I will definitely think more about autoimmune and genetic condition right now.
Yeah, I think that the slowly progressive nature of this disease is very much in keeping with something that's autoimmune or something that's genetic. And the question is autoimmune and genetic or genetic potentially of what? And I think the unusual feature in this case is the presence of inflammation. You ask yourself, how many patients with Duchenne's or mitochondrial disease have oscillating fevers that require Tylenol? And I think the other interesting aspect, Johann, is the possible involvement of the GI tract. So I'm curious how the fevers and how the decreased bowel movements alter your or influence your analysis. What happens with them?
Yeah, I mean that's interesting, but we also have to keep in mind that the patient has, you know, a J6PD. I mean, I know J6PD will give you more jaundice and a hemolytic type of presentation, but overall, you have other condition that can just maybe intolerance to
Mm,
these or these elements of the diet can definitely lead to weight
mm,
loss if it's not controlled, depending on how the patient was followed during his life. Because I feel like at 18 you started being maybe more independent. You start thinking things you weren't thinking before. You started eating new things. So I
mm,
just keep that in mind. But I don't
mm.
want to blend everything because the picture is so blurry now.
Yeah.
Now he's on a wheelchair. He has J6PD, fever, weight loss. So there's so many information, and I don't
Mm,
want to just mix everything in
mm,
one box and say, okay, everything is linked.
yeah.
So personally, regarding the myalgia and the muscle weakness, I don't see a lot of condition that can, give you fever and unintended weight loss linked to that. Maybe an insidious malignancy, maybe, with maybe a paraneoplastic syndrome, who knows? But overall, I don't think there is a lot of condition of autoimmune condition that can, give you the myalgia, the muscle pain, and muscle weakness, plus fever and weight loss. So I don't want to mix everything for now.
Yeah, no, I agree with you. I think that, as you said so well, the picture is very, very blurry. And I think the key thing is going to be to examine the patient to see if they have neurological weakness or they have asthenia, a sense of weakness. Because I think that it's very plausible that a patient has a systemic inflammatory wasting syndrome. And as an expected feature of that systemic inflammatory wasting syndrome, their muscles don't feel good. That's very, very different than a systemic syndrome featuring muscle weakness or loss of muscle function. So I think it's going to be crucial to establish whether this patient's muscles bother him or they don't work. And I think if they bother him, investing in them is probably going to be lower yield, no different than somebody who has a systemic syndrome with a headache or nausea. These things can be artificially localizing, but may not actually hold the house of the disease. So I, like you, I'm very curious where this space goes. And I don't think we've clearly defined our problem yet, but I suspect we'll make tremendous progress with careful attention to the neurological exam. So very, very well said. I admire your ability to pause and not push yourself forward and acknowledge that it's blurry. And we first need to see more clearly where the problem is before we start tackling it with more vigor and momentum. Awesome job. All right, Ibrahim. Story time again.
Yeah, thank you for the awesome discussion. So continuing on the HPI, you try to elicit more information from his mom, and she tells you that the patient has a positive history of unpasteurized sheep milk ingestion since he was a child. And 2 months ago, he had unpasteurized camel milk ingestion. I do have to say, however, that this is something I see commonly at my teaching hospital, just because it serves a lower income bracket of the population. And so this isn't something uncommon. The mom also tells you that during his last hospital admission at an outside private hospital, he had a bone marrow biopsy as part of his workup, but they never had the results back. As for the past medical history, apart from his most recent 4 hospital admissions, his last hospital admission for his G6PD was 2 years ago, but he's not known to have any other chronic diseases. And when it comes to family history, his mom tells you that this patient has 8 other siblings. One of his brothers passed away at 8 years old from a hematological disease. We tried figuring out what that hematological disease was, but unfortunately, we didn't have the patient's files at our hands, and so we couldn't figure it out. Otherwise, family history is negative for malignancy, but is positive for consanguinity. And for allergies, there is no known allergies in this patient. So you do a physical exam on this patient, and it was unremarkable except for the following. So you note a hepatomegaly 4 centimeters below the costal margin and splenomegaly 5 centimeters below the costal margin. You do a lymph node examination and you find 2 palpable cervical lymph nodes in the right and left, rounded, mobile, but no axillary palpable lymph nodes. And for lower limb examination, there was no lower limb edema or signs of DVT. And you do a neurological examination, but you find out that the patient has intact power and tone, but cannot fully extend his leg because of the pain, although no tenderness on examination. His knee appears normal with no signs of infection in either of his 2 lower limbs. And I'll leave you with that.
Wow, Ibrahim, absolutely amazing. I just want to have one clarifying question and also give you time, Johan, time to collect his thoughts. Ibrahim, where was the pain when the patient was trying to move? Was it in his back, his legs, or where would he say it hurt the most?
Right. So because the patient was unable to speak at the moment, uh,
Hmm.
we could only, I guess, figure out if he was in pain or
Yeah,
not by his
I see.
facial features.
I see.
Uh,
Understood.
so
Understood. You couldn't quite tell where he was hurting. So Johan, I just want to acknowledge for everybody listening to see how myalgia and muscle weakness, not muscle function problem, and how easy it is to fall into the trap. We do this all the time. Like, oh, patient says, oh, it hurts in my muscles and they're weak. Oh, you must have a muscle problem. Look at that power. We're now solving a completely different problem than I had anticipated initially. And that's why it's just so important to be open to the possibility the patient does not have a muscle disease. No different than when somebody says they have a headache, but the real answer is actually that they have COVID very far from their head, but their head hurts. So now that we're in a very open space, I'm curious what parts of this data caught your eye and what you think is important here.
I mean, the physical exam is just amazing and it's just so rich with the hepatomegaly and the splenomegaly and the lymphadenopathy. So right away with that picture, just start thinking the patient is 18 years old. I just want to, maybe do a slam dunk and say maybe it's APL, for example, but it's just so rich and it makes me think about, hematology causes as well, especially, you know, um, maybe AML, I mean APL mainly, which can present with bone pain. Maybe that can explain the muscle pain that he was talking about, but it was actually bone pain. So they're trying to explain the chief complaint as well again. And his cachexia, having fever and weight loss is also so common in hematologic malignancies, that type of B symptoms, how we call them. So I think it's, the global picture now, push me toward hematologic malignancies more than anything else as of now. So I'll, instinctively I will think about, hey, do I have a blood smear to check if there is anything there? And also the hematology will be, I'm sure the CBC will be really rich. And if we can have also a bone marrow biopsy afterward too, I'm sure first with the CBC we'll have way more information. But as of now, with the physical exam, I'm definitely leaning more toward hematologic malignancies than what we previously talked about.
It's amazing how the problem really now is defined, right? I think now you can say, oh, this is a subacute progressive wasting syndrome with features of inflammation, as evidenced by the fevers, and reticuloendothelial activation as evidenced by hepatosplenomegaly and lymphadenopathy. And I think that differential is very evocative of primary reticuloendothelial disease, i.e., lymphoma or leukemia. And the journey towards a primary reticuloendothelial disease has to first include easy tests that can look at that, like you said, peripheral smear, flow cytometry potentially, and re-review of information collected beforehand, including the bone marrow biopsy. It's already there for free if you can access it, which is sometimes difficult. But you can never diagnose a liquid malignancy without first exonerating infectious, especially infectious mimics. And so I think if I were putting in admission orders for this patient, I would ask for peripheral smear first. But then I would wonder, okay, what kind of infectious diseases do I have to think about in this circumstance? So I guess the question for us to talk about, Johann, is if we're putting those admission orders in together, we'll probably be much wiser about what to put in after we get the basic set of labs. So why don't we get the next aliquot? But I'd love for you to be thinking about, realistically, the ED is going to call you after those first labs come back. And so let's see how they enlighten us. But in addition to figuring out what this patient has, I'd love to put all of us in the shoes of what is our admission testing. And so why don't we get that data from Ibrahim to shed light on how that space is influenced, and we'll pick up this conversation then.
So,
All
all
right.
right. Yeah. Thank you, Ravi. Thank you, Juan, as well. So, ask and you shall receive. So this patient did, in fact, have a blood smear as part of their initial workup. And on the blood smear, there were no abnormal WBCs seen, but there was mild increase in lymphocytes and monocytes, plus polychromagia, plus anisocytosis, and moderate thrombocytopenia noted as well. As for their coags, they came back with INR being at 1.4, a PT at 16, and an APTT at 45. As for their CBC, it came back with a hemoglobin at 7.9, with a hematocrit at 24.7, and an MCV at 87.8, and a white count that came back at 2.3, with a neutrophil count of 0.64, a lymphocyte count at 1.18, and a monocyte count at 0.45, and a eosinophil count at 0.02, and a platelet count finally at 55. At that point, he was admitted under IM as a case of pancytopenia for workup, and he was transferred to the ward. One day after he was transferred to a ward, he had a fever spike of 38.9 Celsius, and as well as a headache. And so we sent for septic workup, and we started the patient on cefepime. So back to you.
Amazing. Absolutely amazing. So, Johan, I think it's very unfair for me to ask you to put in admission orders for such a complicated patient without giving you some time and also some help. I think it's a great time for us to do a little bit of a breakout room. So you're Johan, you're with a star-studded crew of Julia, Kushal, and Noah. So I'd love for you all to chat, huddle together, and then we'll just come back in 2 or 3 minutes to allow everybody to talk. And then we'll hear your thoughts and we'll make some progress together. Okay. I do want to
All right.
offer you, do you have any clarifying questions for Ibrahim before we go into the breakout room?
Yeah, so Ibrahim, just for the differential for the WBC. So I just want to like neutrophil because in general it's in percentage, right? So it's 64%, and lymphocyte it's 11%, monocyte it's 4.5, right?
Uh, and this is actually also, unfortunately, our AMR does not report percentages, it reports counts. So this is the count of the neutrophil.
No. I'm just talking about the differential. So neutrophils, lymphocyte, monocytes. I mean, can you
Uh,
just tell me if it's high or low?
I can try to explain because my lab is just like yours, Ibrahim. So the total white count is 2.3, and half of the white count, 50%, is lymphocytes, 1.18. And everything else is less than a third of the white count.
All right.
So the patient, if I were to translate that, the patient has leukopenia with relative lymphocytosis. And then everything else is low. Just like my lab. Very, like Ibrahim was saying on Tuesday, our lab, his lab very, very, very much functions like labs in the United States. Alrighty. So folks, if you can join the breakout room, I highly encourage you to share your thoughts amongst each other, unmute and chat, and we'll come back in about 3 or 4 minutes, okay? All right, Johann, you've had some wisdom shared with you from the Academy members. What are your thoughts so far?
So I had a really, really interesting conversation with Julia and Noah mainly. And first we were talking about the overall presentation. The peripheral smear wasn't really helpful because anisocytosis, I think we call it teardrop cell, and it basically presents in any hemolysis overall, especially since the patient has J6PD, so it wasn't really helpful. And for the rest, it didn't really help me. I mean, I didn't see like error rods or any type of specific thing on the smear, so it wasn't helpful, but the CBC itself was really rich. So having, low WBC, low hemoglobin and low platelets, I was thinking about MDS or maybe APL regarding the age of the patient. And Noah and Julia added something really meaningful is if it's not lymphoma and leukemia, what could it be? So we started talking about Vex's syndrome and all the other pathologies that can give you MDS as well. So overall, personally, I still lean toward hematologic malignancies, especially. I mean, it'll be way more common than anything else regarding this presentation. So I think the the bone marrow biopsy will definitely help. Even the chemistry, we can have more information with that. But this is where I'm leaning right now. How about you?
Amazing, absolutely amazing. Okay, let's play a game. I wish Parisa were here. I love these games. So Johann, separate from this case, okay? Sorry, Nara is licking. Oh, stop it. Okay. Sorry about that. Separate from this case, you have a patient who presents with a classic presentation of the most common aggressive lymphoma, diffuse large B-cell lymphoma. What do you think their time course is?
So I think for diffuse, the diffuse large B-cell lymphoma, I think first in general so it start with, for example, another type of B-cell lymphoma, and then it's turning to diffuse B-cell lymphoma. That's my understanding.
Good.
So it
Okay.
will be sort of chronic with, but not really aggressive, and at some point it
Yeah.
will be start being really aggressive.
Boom.
That's how I see that.
The lymphomas come in two flavors, indolent and aggressive. Indolent lymphomas will slowly progress over years to decades. Aggressive lymphomas will progress either with or without a prior history of an indolent lymphoma, either occur spontaneously or in the background of an indolent lymphoma over weeks. I don't know a single lymphoma that progresses over 8 months. Like this. Same for leukemia. Acute myeloid leukemia, acute lymphoid leukemia, weeks, days sometimes, like Sousen's case. Chronic, CML, CLL, years. The time course here pushes us and gives us caution to diagnose liquid malignancies. It's a very beautiful story of how things evolve. There are very few lymphomas that slowly start to eat away at your core organs over the time course of 8 months. Very unusual. And in fact, this time course, you might say, is also relatively inconsistent with some infections. TB causing wasting over 8 months without taking the patient's life? 8 months of untreated TB? 8 months of untreated histoplasmosis? These two are the leading causes of a febrile reticuloendothelial presentation that are infectious in nature, TB histo. And so I think the time course here is very, very powerful. And I will share with you that there are a very small number of infections that present with a time course that is progressive over almost a year. If you scrutinize our VMR database and your real-life experience, most chronic diseases like dementia progress over years. Most subacute conditions progress over weeks. Example would be lymphoma, tuberculosis, histoplasmosis. Acute and hyperacute diseases we see all the time, strokes, altered mental status. A subacute progressive disease on the order of months is a super rare subset. And I will pull up a schema to show you the infections that do this. And I'd love for you to think of what infections you think might do this. But I just need a second. Sorry, I should have pulled it up earlier. Here we are. Okay. So here's my quick checklist. I'll always have to get an HIV test. It doesn't explain many things here. Are there any infections on here that you know can cause a febrile hepatosplenomegaly presentation?
So I think overall, I think blasto and oh, wait, what?
Say that again?
Yeah, I think blasto and I mean I no longer see your screen, but I think most of the fungi can definitely cause hepatosplenomegaly. Yeah.
Yeah. A lot of these you should be suspicious of for sure. Whipple's disease doesn't usually cause hepatosplenomegaly. Actinomycosis does not. However, brucella and mycobacteria notoriously do. The story of brucellosis is fascinating. It causes what's called undulating fever, where a patient has periodic fever, like malaria, but over a much longer time course. I would be very, very suspicious of brucellosis in this patient. And the reason I know that is because as somebody who grew up in the Middle East, brucella ravages the Middle East, much like tuberculosis does. And with this patient's unpasteurized milk exposure, I think the focus initially, as we talked about, the journey will end with lymphoma and leukemia. But the first phase should be, is there activation of the reticuloendothelial process by an infection? And I think TB should be ruled out, of course, but I would be very, very worried about brucellosis in this patient. And the reason I would be worried about it, Johann, is because it can be very hard to diagnose. The best diagnostic test is the bone marrow biopsy. But if you're not thinking of it, looking for brucella in the bone marrow, you won't see it. So I think, he's spiking fevers, he's sick. I think focus should be on infection. And my worry would be in a patient who has the exposure, unpasteurized milk, to really thoroughly investigate brucella. Now, it's a rare infection in the world. It's not a rare infection in patients who have unpasteurized milk exposure. So that's where my angst lives, is I hope that we haven't missed that, because it would be really sad for the patient, but we can potentially turn things around. So I would make sure that we turn every stone before we exonerate brucellosis in this case. Any thoughts or questions about that?
Not at all. I think you're 100% right. So the overall pictures with the I think the camel milk, the undulant fever, and the hepatosplenomegaly fits with brucellosis. The only thing I'm not sure is the actual CBC. Like the picture on the CBC is pretty grim. So do you
Yeah.
think brucellosis can give such a grim picture on the CBC?
Unfortunately, yes. It should not, but in advanced disease, it completely granulomas replace the marrow, causing prominent pancytopenia with predominant neutropenia. So, not usually, no, but when it's left untreated for this long, it can. There's a very famous New York Times case written by Dr. Lisa Sanders, who you might know for her Netflix documentary, where a patient had untreated blue cirrhosis for 5 years. Can you imagine an infection that's progressing like this for 5 years? It's a very, very unique time course. And that patient had a very similar CBC. All right. Well, and I think, Johan, I'm at risk of over fixating on a diagnosis, brucellosis. And you want to be careful. In real life, you don't want to be like, oh, this is brucella until proven otherwise. But the reason for this hypothesis in this patient is because it is very important to rule it out. Now, we shouldn't just pretend that it's brucellosis and we're done, but I think we need to cast a very wide net on all the things you mentioned. But brucella needs to be our first mode of investigation because of its treatability. And because if we accidentally diagnose a lymphoma, immunosuppress the patient, we risk harming them a lot if we don't really exonerate brucellosis. Alrighty, Ibrahim, the mic is yours, my friend.
All right. So thank you, Ravi, and thank you, Johan. So we sent out for a septic workup, and it came back negative. And ask and you shall receive. We also sent out for other stuff, including a hepatitis panel, which came back negative. Malaria came back negative. CMV came back negative. Brucella came back negative. A gold quantiferon TB came back negative. A malaria, yeah, I already said that. Malaria antigen came back negative, as well as a smear. And a dengue test came back negative. We also sent out for a couple of tumor markers, including a CEA, a CA 19.9, and a CA 125, and a CA 15.3, which all came back either at borderline low or unremarkable. And the next step we did was that we did the pan-CT as part of a fungal search. I'm gonna share my screen and show you the pan-CT if you can. So this was the, and let me know if you're unable to see my screen. So this was the neck and brain CT. Fortunately, no axial images that I could find in the system. So this was for the CT neck and brain, and then we also had a CT cup, which came back as follows. Uh, so I guess back to you, Rabi and Johan, and I'm gonna keep sharing the screen while we discuss this aliquot, just in case, just so that you can have more time to look at the imaging here.
So, Johan, I'll say that interpreting the CTs is very, very tough, especially when many people are watching you. But I'm curious, did anything jump out to you?
The first, I mean, the thing that is just shocking is the huge size of the liver. That's the
Yes.
only thing I see. A huge liver, a huge spleen.
Yeah.
Regarding the head and neck CD, I don't know if Ibrahim can show it again. I didn't really have the time to examine everything, but the abdominal CT are part of the huge liver and huge spleen. I don't see anything else.
Yeah, I couldn't. I was looking to see if the lymphadenopathy that Ibrahim described on exam could be seen on the CT. I couldn't see it either, honestly. My observations were just like yours: big liver, big spleen. I was looking at the bones closely to see if the patient has any bony pain to explain why he's in pain. I couldn't see anything myself. So, Ibrahim, what was your interpretation or the radiology interpretation of the CT scan?
Alrighty, so the radiology report was a bit extensive. So I'm just gonna go over the most important stuff. So for the CT neck and brain, it came back as the following. The conclusion was no definite intracranial metastases, nodular enhancement at the subarachnoid space of the left occipital lobe, which might be part of a superficial vascular structure for eventual correlation with a brain MRI, enlarged right level 4B lymph nodes, as mentioned above. And for the CT cap, the conclusion came back as the following. In the report, they noted that there were enlarged lymph nodes in the portohepatic, the peripancreatic, and the gastrohepatic, as well as the aortocaval group. And the conclusion was hepatosplenomegaly with mild upper abdominal lymphadenopathy. As described, the appearance can be attributed to an infiltrative neoplastic, non-neoplastic process like lymphoma, leukemia, or infections for eventual histopathological correlation. Um, and so eventually the patient was discontinued of cefepime on day 3 because he was still spiking fever despite a normal septic screen. We then consulted IR for a lymph node biopsy, and they told us that it wasn't possible. And I've mentioned that during his last hospital admission, he had a bone marrow biopsy. And at this point, the family was able to bring back the slides from the outside clinic where they did the bone marrow biopsy. And it had shown highly cellular bone marrow with increased histiocytic cells at the extent of myeloid cells. And at that point, we consulted hematology and oncology, and they asked for a repeat bone marrow biopsy. The repeat bone marrow biopsy came back as the following. So actually, the pathologist, as soon as he saw this, he called us, he called the team. He didn't wait until the report was into the EMR. And he said, and I'm quoting here, a striking hemophagocytosis, but still waiting on the report. And eventually the report came out and it showed a hypercellular bone marrow with prominent hemophagocytic activity. And I'll leave you with that before the final aliquot that would reveal the diagnosis.
Johan, I'm sure you woke up this morning saying, I can't wait to discuss hemophagocytosis, given that there's a 20% chance of HLH featuring on VMR. But I want to pass the mic to you just to get your spontaneous thoughts. I just really want to commend Ibrahim for such an outstanding case. This is, whatever the answer to this case, this will go down in the VMR legendary case files for sure. Very, very fascinating and unique case. And I'm sorry that it's your first ever discussion having to discuss such a difficult case, but all along you've been up for the challenge and seeming to have a great time. So what are your thoughts?
I just feel like I'm in Jeddah right now with Ibrahim, seeing that particular patient. It's amazing. And what a twist! What a twist with the result of the bone marrow biopsy. I really wasn't, I didn't actually think about having HLH here, but it's definitely a possibility. I think someone saying in the group HLH with MDS. I think it definitely fits the picture overall. And yes, I think Ibrahim, how many aliquots do you have left?
Yeah, so once you and Robbie are done with this aliquot, I'll reveal the final diagnosis in my next one.
All right, okay. So yeah, I think overall it fits with the picture. I was pretty surprised that the brucella the brucellosis was negative. After the discussion, I was leaning toward brucella as well, and to see the bone marrow biopsy now with the hemophagocytosis, I feel like it's a big twist. And I just want to learn more I wonder what you think about the case, and also the reflection of Ibrahim.
Absolutely. Yeah, no, I think that maybe Johan, I can ask you just one question, just to make a teaching point out of something that you said very eloquently. Are you surprised, authentically, are you surprised that you're dealing with HLH in this case? And if so, why are you surprised? What is surprising about that?
I mean, I'm surprised first because for the way Ibrahim started the case and
Yeah,
all the twists and all the intricacies that are in the case, starting with so some sort of polymerized pictures, then
yeah,
switching to leaning more toward APL or more traditional
right,
leukemia, and now ending with
right,
hemophagocytosis
right,
with
right.
low hemoglobin and low platelets. Now, I don't know. I really don't know how to. I just didn't think about it.
Yeah, me neither. I think it's very unusual. In fact, within a rare disease, HLH, it's very rare to have a subacute progressive phenotype. The vast majority of patients with HLH aren't at home, they're in the ICU. And the very defining feature of HLH is a very hyperacute, devastating, febrile illness where patients can't leave the ICU until they get anti-inflammatory treatment. That's because the vast majority of patients with HLH have a very vigorous acute trigger, a very bad infection, a very bad autoimmune disease like lupus. In fact, yesterday's UCSF morning report was a devastating case of lupus causing HLH in a very sick patient. And here I am, 24 hours later, discussing HLH with the exact opposite time course. And I actually, Johann, in full disclosure, had no idea that HLH could exhibit this time course until Jas presented a case of MDS, which you said, triggering HLH in a much more indolent, slowly progressive manner. And it taught me to essentially try to create a schema for prolonged subacute progressive HLH. And one of the most common causes is actually genetic HLH, which can progress very slowly. And we don't have time to dive into HLH, but I wonder if this patient's consanguinity and prior hematological disease puts them at risk for primary genetic HLH. The other triggers, in addition to MDS, that are secondary, that progress over a slow period of time, include very, very slow infections like brucella and leishmaniasis. And so I think the brucella antibody is a great negative predictive value, but I'm sure the pathologist will look at this bone marrow and make sure there aren't any brucella organisms or Leishmania mastigotes on the bone marrow. That would be huge. But the most common causes are all the autoimmune diseases that induce HLH, with the most well-described one being Langerhans cell histiocytosis, LCH. So I think the reason this case is very unusual, it's of course a case of HLH, but it's even more unusual because it's chronic HLH, which often leads to the conclusion that the patient has genetic mutation in immune regulation, but a search for chronic triggers like chronic infections, chronic hematological diseases like MDS, but also chronic autoimmune diseases like Langerhans cell histiocytosis. So I think the answer is always in the tissue here. And I, like you, am very eager to learn from Ibrahim because this is a space I've only encountered once before with Jas's case, not enough to have more confidence. So I'm definitely going to be learning a ton. All right, Ibrahim, the mic is yours.
Quick
Yeah, so
question.
Oh
Quick
yeah, go
question,
ahead, Johan,
Ibrahim.
please.
On the family history, you said the 8 years old brother passed away from a hematological condition. Was it HLH?
so unfortunately, once again, AMRs here are not connected. So it can be a little bit difficult to get the full idea about the patient's presentation. The only thing the family knew was that it was a hematological disease, but they couldn't tell if it was a malignancy or otherwise.
Okay.
All right. So thank you, Johan, and thank you, Robbie, for the discussion of this aliquot. I truly learned a lot just from your discussion on this case, even though I saw the patient while they were on the ward. So for aliquot 7, as per hematology and oncology, they asked us to they asked us to rule out HLH. And so we sent for a ferritin, which came back at 1,420. And the LFTs were as follows. Their Billy was at 78. Their alk phos was at 1124. Their total protein was at 61. Their GGT came back at 259. Their ALT came back at 653. Their AST came back at 479, and their haptoglobin was within normal limits. Their lipid panel came back as the following. Their HDL was less than 0.13. Their total cholesterol was 6.09, and their triglycerides came back at 3.13. And at our institution, we consider anything above 3 as high. Their interleukin-2 receptor came back at 15,900. Their ABV viral load, their ABV quant, their ABV IgM, all were negative, but their ABV IgG was at 120. We sent out for a Wes from his bone marrow sample, and it came back positive for PRF1 mutation. And so this patient was eventually diagnosed with primary familial HLH and was started on HLH protocol at our institution.
Johan, what are you thinking?
Wow, what an amazing case, Ibrahim. I will definitely, after this morning report, go back and read everything about HLA because I wasn't expecting this because I was maybe I don't know, acute pancreatitis. Loss of consciousness. I was thinking about this type of topic for my first case, and I'm glad to have such a, deep and complicated ca case with so many teaching points. And I'm really glad that you presented this case today. And yeah, definitely, I will go back and review this case again, and I've learned so many things.
Johan, I think you modeled just how tough it is to solve this case by articulating your thoughts with so much clarity and clearly very honest and open about the things that you don't know. And I think as a generalist, knowing about primary HLH is not something that you'll ever be responsible for. So I think the fact that you rid this journey and shared your thoughts so clearly and eloquently along the way was a lot of fun. And yeah, we had a lot of twists and turns, from a primary muscle disease, thinking about mitochondria, we went back to genetic, but a genetic in a whole different world than hematological disease. Ibrahim, I'm curious, how did the patient do, and what were your reflections on the case?
Right. So honestly, Ravi, just like you and Yohan, we had no idea from the start that this patient would end up having HLH. We kept thinking about TB, brucella, other infectious causes. We thought about malignancy as well. But I don't think that the thought of HLH crossed our minds, at least in the first few days that they presented to the hospital. So this patient, I think the most striking thing that I'd learned from this case is the CNS involvement that caused them to primarily present with the myalgia picture that they had upon presentation. And it seems that this is more common than usual, and it actually has certain, like there are certain radiological clues on CT or brain MRI that can help you in figuring out whether this might be HLH or not. But they're still not well understood, and there's a lot of work at the moment to actually characterize these findings um, so that they can help in at least cluing physicians onto grasping onto HLH from the start. For this patient specifically, their lower limb weakness became way better after they were started on the HLH protocol. And the protocol at our institution is dexamethasone, cyclosporin, and etoposide. And on day 9, they were actually able to go to the bathroom on their own. And eventually they were able to walk around the ward, and they were discharged at day 42. And they're going to be following up with hemonc as well in the outpatient setting. So I just wanted to just, I guess, give a brief teaching point about HLH and its findings in the CNS. So there are actually three stages upon which HLH can present in the CNS. And typically stage one is the least severe, with stage three being the most severe. So stage one, if you see something like leptomeningeal infiltrates, um, or if you're able to see histiocytes or macrophages, if you're able to get the histopathological diagnosis from the brain from the beginning, this is typically stage one. Stage two may show additional parenchymal involvement with perivascular infiltrations. So this patient did have some perivascular infiltrations in the occipital lobe, which we think might be attributed to his eventual HLH diagnosis. But even the radiologist did not comment on that just because it's not as well understood. And then stage three, which is the final and most severe stage, would usually show signs of cerebral tissue necrosis with demyelination, in addition to massive tissue infiltration that particularly affects the white matter. Um, Otherwise, I do have to say I had a lot of fun presenting today's case. And I really, really want to thank you, Johan, as well as Robbie, for teaching me a lot. So thank you so much.
You guys are incredible. It's such a privilege to share this space with you, Ibrahim and Johan. A masterful discussion. I can't believe it was your first time, Johan. You looked so calm, composed, and just so full of joy. I think any program who recruits you will be lucky that this is the kind of care that and joy you'll pass on to their patients. And Ibrahim, I think you should write a book at some point because clearly your ability to narrate and bring this patient to life was amazing. It's just such a cool, rich experience. And I think now we get to top it off with teaching points from Masa. The mic is yours, Masa. Oh, I think you're muted.
Oh, sorry.
There you
Is it better
go.
now? Okay, thank you so much, Ibrahim, for this case, and great job, Johan, on the amazing discussion. So this was a case of an 18-year-old who presented with progressive myalgia, diffuse muscle weakness for the past 8 months. So this is a chronic time course. So we want to know why the patient presented now. Is the disease getting worse, or are the symptoms getting worse? Is there a change in time course, or did it reach a crisis point? So we want to identify the problem. So for progressive myalgia, we want to know if he's able to exercise, is it painful when he touches the muscle, and just explore genetic or autoimmune diseases. For the skeletal muscle pain, so this is pain. If it's pain on its own, this might mean like an acute vascular insult like rhabdomyolysis, could be from a substance like cocaine, or a mismatch in supply and demand. This is akin to acute coronary syndrome, where they only have chest pain as opposed to heart failure. And for the diffuse muscle weakness, we want to know if it's real weakness, or or is there like a real muscle component to it. This could be a neuropathy, an endocrine problem, electrolyte issue, or like a depression. So the muscle weakness with the pain makes us think of necrotizing muscle diseases. So it's important to examine the patient, focusing on neurologic exam. The fevers in this patient make us think of an inflammatory process. So we want to figure out if it is a systemic inflammatory wasting syndrome, or a different process, or a different syndrome with muscle weakness. And here the hepatosplenomegaly indicates a reticuloendothelial process. So we would need a peripheral smear or flow cytometry to go to the next step. Lymphomas usually present as indolent or aggressive. And indolent lymphomas progress over years or decades, and aggressive lymphomas progress over weeks, whether with or without a prior lymphoma. So this is different to how the patient is presenting here. But anyway, it is very important to first rule out infectious mimics like histoplasmosis or TB or brucellosis. And we were mainly thinking of brucellosis because of the unpasteurized milk exposure. the undulating fevers, and the pancytopenia, because if it's left untreated, the granuloma can replace bone marrow. But ultimately, this patient had HLH, which is a hyperacute febrile illness, and it is usually preceded by an acute trigger like an infection or autoimmune disease. And when we think of prolonged subacute progressive HLH, we think of genetic diseases, and these are the most common, and these progress slowly. Chronic infections like brucella and leishmaniasis, and chronic hematologic disease like MDS, and finally autoimmune diseases like Langerhans cell histiocytosis. And that's it. Thank you very much.
I can't emphasize how difficult a task like that must be to summarize with clarity the teaching points from such a complicated case. So if you have any gripes, Masa, you should send your grievances to Ibrahim, who presented such a such a complex one, but I don't think you need to because you did such an amazing job. That was awesome. Cases like this and days like this fill me with so much pride to be surrounded by the three of you. It's unreal. With a big, big shout out, of course, to Julia, who is quietly scribing away. So thank you so much, Julia, too. I hope you guys have an awesome rest of your day. Bye, guys.